Good morning, good afternoon, good evening, everyone, wherever you are in the world. Welcome to this session of 2021 ILAG. This session is Holistic Provision, the Way of the Future. And I think many of us have a hope that that's where we're going, and we're curious about how to get there. And so I think that we'll learn a lot from what our speakers have to say to us today. Our first speaker is Mr. Toshihiko Mizushima, who's devoted a significant portion of his career to civil law. He's had a specific interest in the guardianship of adults. He's done work in both law and social work, and his activities have included working as a staff attorney at the Japan Legal Support Center. And he's established an advocacy center in conjunction with organizations in that field, local welfare agencies, and so on. And we look forward to hearing what he has to say. Please tell us.
Hello, everybody. I'm Toshihiko Mizushima, a staff attorney in Japan. As a staff attorney, I have been promoting the practice of so-called legal social work, which is to provide comprehensive support to clients in cooperation with lawyers, social workers, and other related parties. In this presentation, I would like to discuss legal social work's challenges and prospects, referring to my past practice. First of all, what is a staff attorney? The slide shows the similarities and differences between staff attorneys and other attorneys. They are both the same in that their mission is to protect fundamental human rights and achieve social justice. And they both work independently. The difference is that staff attorneys are employed by Japan Legal Support Center, JLSC, and are therefore not paid by the client, but paid by the JLSC. Even though the remuneration per case is small, it is said to be an advantage of the salary system to enable us to assist clients in need. JLSC's staff attorneys work in its law offices throughout Japan, from Hokkaido in the north to Okinawa in the south. As of March 2021, there are 87 offices throughout Japan, some located in urban areas and others in remote areas. Depending on the location of the office, the cases that JLSC's attorneys can handle will vary. I will show you a short video in 3 minutes about my activities in Sado Islands. Sado Islands is located in red circle. Don't worry, I put English subtitles in it.方はですね、80代のおばあちゃんで、認知症を患っています。で、お一人暮らしということもあって、私だけではなくて日常生活支援事業の専門員さん、それからケアマネージャーさん、この3人でですね、今回ご自宅を訪問したいと思います。ください。お願いします。お母さん、なんかさっき出られとったの？外出られとったの？
買い物。
あ、買い物にとった
本屋のね、それから赤崎のね、
うん。
食べ物。
あ、そう。あ、
うん
そっかそっか。何買ってきたの？
あ
何買ってきたの？
この24時間とこ。
コンビニな。コンビニの、
うん
触ってみね。こういう、まあ、手紙が届いとるんだわ。見てわかります？読みましょうか。
読んでください。目が暗いから。
わかりました。足が悪いだろうから、面会には来なくても、私一人で、今まで来たのだから、面会には来なくてもいいですよと。お金もかかるし、車もね、危ないからねと。では元気でねということでね、それから手紙来ております。
私、心配しとったんだから。
心配だろう。
こういうかったようなことでね。
そうだろう。なんで今日はこれでね、終わります。で、また何かお困りのことがあったら、いつでも言うてくださいね。はい、どうも今日はありがとうございました。
ありがとうございました。
事案としては、もともと私の方でご相談としては受けていたけれども、なかなかうまく生活が成り立っていかないという問題があって、弁護士だけではどうにもならないので、社会福祉協議会と地域包括支援センターさんに相談をさせていただいた。でその結果として、日常生活自立支援事業、そういったものを使いながらですね、本人さんの、生活を成り立たせようと、そこで何か借金とかそういったものが出てきたときには法廷はその関与してやっていきましょうというような、そういったことで、相談をした事案です。
Thank you for watching. The collaboration with relevant agencies and lawyers is important to ensure comprehensive care and safety for clients. However, I ask myself, did we only offer protective options for our clients because we believed it was in the client's best interest? How we deprived their freedom and rights to make their own decisions in exchange of their safety. In order to answer my questions from 2014 to 2015, I stayed in the UK as a visiting research fellow at the Human Rights Center at the University of Essex, where I researched the Mental Capacity Act 2005 and the UN Convention on the Rights of Persons with Disabilities. I've got the idea of the person-centered approach in these countries. Specifically, the support should be provided based on the person's values, beliefs, preferences, rather than on the views of supporters. I met a great advocate in the UK. She often said, it is particularly important to ask yourself, have I provided the best chance for my clients to make their decisions by themselves? We shouldn't immediately conclude that a person is not capable of decision making just because they do not appear to be able to communicate. Our client's ability to make decisions also depends on the ability of the support person to support decision making. It is important that supporters make every effort to support their clients using all the tools at their disposal, including symbol cards and iPads, rather than relying solely on words. I finally found the client's mental capacity to make decisions depended on the supporter's ability to supporting decision making. After coming back to Japan in 2016, I began working as a member of the expert council to deal with the issues of Japanese guardianship. Following discussions at the UNCRPD at the expert meeting, various guidelines regarding supported decision-making have been issued. Moreover, various training and PRs have been studied to provide practitioners for raising awareness of these guidelines. Lastly, I'd like to share the case of Mr. H, for whom I practiced decision-making support with team members. He is a man in his 60s who suffered from higher brain dysfunction and aphasia due to a stroke. Recently, a demand letter arrived at the care home, which appeared to be a debt for H. It is difficult for H to communicate verbally, and he didn't want to actively express his feelings. He is reluctant to interact with other residents and tend to stay indoors in his room. When I met H in person, he kept looking down with a frown on his face. In the preparation meeting, I have tried to gather a team to promote supported decision-making by H. For example, we discussed the following topics. What kind of personality is H? What kind of life does he want? What values does he hold? What does he like and dislike? What kind of decisions have been made by himself so far? What his preferred method of communication? After that, I concluded interviews with H to use decision-making support tools such as talking mats in order to find H's variant preferences. In the meeting with H, focuses on H's strengths, not his problems. Also, team members didn't force a particular option on H just because it is economically or objectively advantageous. As a result of our focusing on supported decision making by H rather than on intervention by the team, we were gradually able to read H's finger wagging signs, nods, and facial expressions. We were also able to learn about his character with wit and when he wished to live in the current care home with his preferred staff instead of dangerous home. By H's wish, the family court appointed the Social Welfare Council as his guardian because the SWC continually provided him the financial support in the past. I settled H's debt based on the guardian's order, which was successfully completed. The other guardian also applied for H's pension. When the team members hold several meetings with him again and again, he suddenly started counting number verbally. 1, 2, 3. As all the members was very surprised, he grinned with smirk expression. His care staff told us that he had started rehabilitation with a speech therapist at his own request. Legal social work attempts to provide total support for clients by integrating judicial and social welfare services, which have been separated until now. It is also important to provide active support for the elderly and persons with disabilities who have difficulty accessing judicial services. On the other hand, a short-term intervention approach Focusing only on the client's problems or issues may lead to the deprivation of the person's freedom and rights of making decisions by themselves. To provide truly person-centered support, all client team members must share the philosophy of decision-making support based on the supported decision-making guideline and UNCRPD. Legal social work also needs to be changed from the traditional concept of substituted decision-making based on best interests for the clients into the new concept of supported decision-making based on the client's expressed wish and preferences. Thank you for listening.
Thank you very much. That was a wonderful illustration of one of the examples of this kind of model of changing the way that we provide services to people, to think more about them and who they are. Our next speaker is Susie Farrell, who's the Research Director for Health Justice Australia, which is in Australia, the National Centre of Excellence for Health Justice Partnerships. She leads their work to gather evidence on the value of integrating legal help into healthcare settings and healthcare teams and healthcare lawyer teams to improve things like client health and well-being, practitioner capacity, and service efficiency. Susie, we look forward to hearing from you. Thank you.
Hi everyone, and welcome to Sydney. I'm speaking to you from the land of the Gadigal people of the Eora Nation and want to pay my respects to elders past, present and emerging, and really acknowledge the leadership of First Nations communities and services in person-centred care. We're really sorry not to be welcoming you in person, but I'm delighted to be speaking with you today. And I get to share a peek at some of my favourite parts of Sydney and New South Wales. So when we last met in Ottawa in 2019, I spoke about how health justice partnerships were emerging in Australia and the opportunity they present to take a broader lens on the value of legal help. To recap, health justice partnerships embed legal help in healthcare settings and teams to support clients experiencing health-harming legal issues. In Ottawa, I argued that describing the value of legal help in language beyond access to justice allows us to speak about what this work offers to a much broader audience. I made the link between the work of lawyers and health outcomes for patients and health services. I spoke about health justice partnership as a legal assistance strategy and as a health strategy, with a focus on what collaboration between sectors offers each over and above their siloed services. Since then, the number of health and legal services coming together in Australia has increased, as has the interest of health services in the value of legal help. So today I'll update you on Health Justice Partnership in Australia, first as a legal assistance and health strategy, and second as an interdisciplinary learning opportunity. I'll reflect on the impact of COVID as a very real challenge, but also value the sharp focus it has given to the health impact of social inequity and as a catalyst for change. But first, let me set the evidence and policy context for Health Justice Partnership. As this audience well knows, 2 decades of legal needs and access to justice research globally has fairly consistently pointed to the concentration of legal need among those experiencing disadvantage, the clustering of legal problems, and their intersection with other life and health issues. The range of barriers to taking action about legal issues is also well known. When action is taken about a legal issue, we know that help may be sought from a range of sources other than lawyers, including health services. But even when help is needed but not actively sought, legal issues can manifest in health settings as factors that affect patients' health and well-being. An example in our work, midwives and maternal and child health nurses are in contact with women at a time they are very vulnerable to family violence. With training and trusted connections, these health professionals can help identify violence and related legal issues and link their patients with trusted legal help. Responding to access to justice evidence global, national and jurisdictional policies promote services and systems which are person-centred or client-centric. Features of person or client-centred justice services are that they are targeted to the most marginalised by their needs and circumstances, with a view to increased equity and access. They are timely, with a view to preventing the escalation and recurrence of legal issues. They are appropriate and responsive to individual need, and they are empowering through a focus on building legal capability. And they're collaborative and integrated. The OECD also refers to person-centric services as being grounded in empirical evidence around legal need and capability, outcome-focused and effective, with a focus on learning and developing and sharing best practice. And these last 3 points identify services as part of a continually evolving evidence base, both drawing from and contributing to what we know. And this is particularly pertinent at this time of change arising through COVID, where we're having to adapt, respond, test and learn in new service environments. Person-centred approaches are of course very common in health policy and practice and offer a point of connection between legal assistance and health services around shared client groups disadvantaged by intersecting need. And so it's in this context I turn to Health Justice Partnership. Health Justice Partnership is an opportunity to coordinate efforts to address the intersecting health and legal issues that can lead to an entrenched disadvantage. As a person-centric legal assistance strategy, Health Justice Partnership is consistent with the criteria listed above. For health services, legal help is a tool to address factors beyond the medical that are affecting patient health. Broadly speaking, Health Justice Partnership commonly involves legal assistance to individual clients within a healthcare setting or team. In our work on outcomes, we're exploring client wellbeing as the shared measure of this part of the work. Health Justice Partnership involves the transformation of practice and service systems through interdisciplinary training, secondary consultation and collaborative practice. And we're particularly interested in increased health and legal practitioner and service capability to address intersecting need as an outcome of this change. Some HJPs are also involved in shared advocacy for changes to law, policy and practice that can impact on health and wellbeing more broadly. On the ground, health and legal services actually partner in a range of ways, from outreach clinics to integrated services where the lawyer is actually employed by the health service, to multi-agency service hubs and formal partnerships. And together we refer to this as a health justice landscape. Our current assessment is that there are more than 100 services on this health justice landscape in Australia. However, there still is a degree of flux in these numbers after many partnerships ceased on-site services during the height of the COVID lockdowns. Services are also still reshaping their partnerships and ways of connecting with their clients and with each other. And these new ways of working and connecting, including online, are in turn challenging our understanding of what it means and takes to partner for person-centered care. And I'll return to the specific impacts of COVID in a minute, but first want to give you an overview of the landscape here. Broadly speaking, the vast majority of legal partners are public legal assistance services, so legal aid commissions, community legal centres, and Aboriginal and Torres Strait Islander legal services. The sites include hospitals, community health services, maternal and child health services, mental health services, and Aboriginal community controlled health services, among others. In terms of clients, HJPs are reaching and assisting clients with high need for legal assistance services. So lots of legal issues and challenges with reaching legal help. In particular, those experiencing domestic and family violence and mental health issues. Importantly, these clients are not only seen in HJPs that target those particular needs, but across the landscape of partnerships, both specialist and generalist. As discussed earlier, health justice partnerships provide an opportunity for health and legal services to work differently around complex need. Compared to legal services in standalone locations, the activities that partnership enables include secondary consultations, where professionals can consult with each other about a shared client or issue. Capability building through the interdisciplinary training and just the shared practice of working together. And collaborative health and legal care around clients with complex issues, such that each service can play its part in support of and supported by the other. Acknowledging that Australia's fared incredibly well so far through COVID relative to others globally, major impacts here have been the lockdowns, the often sudden border closures, service closures, and of course economic issues arising. Impacts on people's mental health and increases in family violence have also been of key concern. In terms of service delivery, we've heard from our network of practitioners that partnerships have been better able to maintain services when they have strong existing relationships, inclusive of effective referral and communication pathways, and a sense of shared ownership of the partnership, often with shared governance. In other cases, there have been fewer secondary consultations, fewer referrals, fewer team meetings, and a sense that it's been hard to keep the partnership alive or thriving. Challenges to service delivery through partnership have included health services needing to pivot and prioritise the immediate COVID response. Clients no longer coming into health services in person or at all. And lawyers, of course, not being able to work on site. So there was less scope for health and legal practitioners to engage with each other around their shared clients. The move to online or phone-based service delivery to clients has had positive and negative effects. More flexibility, for instance, but also the risk of excluding some clients. We're still exploring what partnership and connection will look like as we live with COVID-19. What is genuine collaboration beyond co-location in the digital space? And we're exploring how to maintain connections, not only between clients and services, but between the partner services. So I've spoken a bit about the challenges COVID has presented in terms of maintaining services and partnerships. But in discussing health justice partnership as a site of learning, I'd also like to reflect on the opportunities presented through COVID, as difficult as it has been. Necessity has seen opportunities and openness to new ways of working and connecting. An increased recognition of and investment in addressing issues such as economic loss and mental health and family violence that do intersect. And a greater sense of how these issues intersect and how solutions to these issues require an integrated response. Foundational work between Health Justice Australia and Health Justice Partnerships now situates us in a really good place to take this opportunity and learn more about the practice and value of collaboration in this new world. Our early research has explored what partnership looks like across the health justice landscape to identify the common activities and features, as well as how services differ. As we gather information about outcomes from different partnerships, we aim to identify how different features and activities contribute to and challenge effective practice and outcomes. To identify outcomes, we've worked with a number of HJPs and researchers to co-design an outcomes framework for health justice partnership as a legal assistance and health strategy. And we've been asking about what legal services gain from working with health, why health services partner with legal services, and their shared value for clients that they hold at the centre of their work. Our theory of change identifies 5 beneficiaries of health justice partnership: clients, clearly, but also practitioners, partnering services, funders and government, particularly those interested in complex need, and communities. And we're exploring shared metrics for these outcomes with a particular focus on client wellbeing, recognising where person-centred care of health and legal services together had a shared impact. We're interested in the wellbeing for practitioners, particularly in the context of the impact of COVID, client capability and empowerment, and importantly, practitioner and service capability to more effectively address intersecting need and as a site of longer-term service system change. We're looking to pilot measures in existing and emerging partnerships and are keen to work with others to do so. We are also looking to bring services together into a large multi-partnership study, which will nest a number of sub-studies: a data linkage study to explore health and justice outcomes and wellbeing, an analysis of the features of partnership and partnering, particularly in this changed service environment, and a study on the impacts of partnership on practitioner and service capability for person-centred care. So if your service is part of an HJP and you're interested to participate, please get in touch. Recognising the foundations and leadership of the HJP movement in Australia by legal practitioners, HJA has been championing this work with health services. 2 papers to support that advocacy are on the slide. And we are seeing real interest expressed by health services in the opportunity to embed legal help in their service strategies to help address the social issues impacting upon patient health and treatment, and to build the capacity of their practitioners and services. To test and learn more about this way of working, the study we're involved in on the impact of childhood adversity on mental health is one example. Indeed, the most recent federal budget in Australia has identified the intersection between health and legal need, particularly around mental health and family violence. Funding to health and legal assistance sectors around these issues provides even greater scope for services to partner across sectors to provide person-centred care for the shared clients with this intersecting needs. It's also an opportunity to explore questions such as what impact does legal help have on health outcomes, and who else might invest in this work? What are the costs and benefits of collaborative or partnered services? And post-COVID, what does collaboration compared to siloed service delivery look like in a partially online service delivery context? So summing up, COVID-19 is shining a harsh light on the intersected nature and impact of health and social inequity. It's also challenging the way we respond to these issues, but also presenting new opportunities, and I would argue new incentive to work collaboratively through strategies including health justice partnership, and to test and learn as we do so. So thanks for your time, and I really look forward to discussing all of this when we meet. Thank you.
Thank you very much. And you've made us feel even more acutely sad that we're not with you in Sydney to see all those beautiful pictures. I want to encourage everyone to put their questions and their comments in the chat. We have one question I'd like to start with, which is very much at the ground level of people's experience. And to both of you, in your research or in your work as a direct service provider, have you run into people who resist a holistic approach and want to focus on kind of the immediate problem? And if you have, or if you've run into it as a research question, how should we think about it and how should we respond to it? Because that wish on the part of the client is kind of part of the client-centered approach. So what should we do?
I mean, I'm not thanks, Becky. I mean, I'm not a frontline service provider, but I think you've answered the question there, Becky. In when it's a client-centered approach, you listen to what the client is asking for. But I think others who are working on the ground might have something more to offer about that. Toshihiko, I don't know if you had something you wanted to add there.
I could say something.
Go, Hazel.
I might as well, since I'm here. Just to say that, hi, everybody. Just to say that from having run, I'm going to speak very briefly about the health justice partnership that we ran for a couple of years. But just to say that we didn't encounter resistance from clients, from patients or who were clients, who actually were just very happy to be referred to a service that could help them, or that they felt would be able to help them. And in some cases, although we had odd bits of resistance from health practitioners initially, who sometimes had difficulty with the concept of legal advice, and they always see law as being kind of threatening because they think about it in relation to medical negligence. Once they understand that we're talking about social welfare legal services and what social welfare legal support, actually the majority of health practitioners get it very quickly and are very happy to in principle collaborate. In practice it's a little bit harder to fit it into their normal patterns of work, but in general actually very open to the idea. So we haven't encountered massive resistance either from patients who welcome any service that's being offered to them to deal with their problems in a holistic way, because of course often, as we know, they have a range of complex challenges, but also a lot of interest from health practitioners once they understand what it is that you're offering and how you can add to the service and actually take some of the burden from them. All right, I'll be quiet now.
So thank you, Hazel, because that actually takes us to the next level, which is, what are the incentives for practitioners to share information across these disciplinary lines? Like, why should they do this?
I've never known lawyers to be shy about sharing their knowledge myself, but that's just a general observation. But I mean, I think there's huge incentive in sharing knowledge, and particularly when you're talking about partnership and you're talking about shared goals. And if that shared goal is improving the lives of shared clients, then there's huge incentive. But it does take trust and it does take relationship. So, you know, I don't think you can just force relationships, and also it builds over time. That when you see and also appreciate that what the skills you bring add real value to the client, but they're not the only skills and they're not the only needs of your client. And so to really be in a space where you can see the value that the other professional brings, that really does open up the space for sharing knowledge.
I completely agree with that. And the medical practitioners that we've dealt with are people who have recognised that their patients need something other than medicine, but they don't feel in a position, they don't know exactly what it is that they need, but they know that whatever it is that they need is not something they can give them. And when they see that you're offering a service that can help the patient, it helps to get the patient out of the consultation, but in a positive way, feeling that they're giving them something. And it takes a bit of the pressure off practitioners who just kind of feel at a bit of a loss. And the other thing I would say, which I'm going to say at the end of my brief presentation if I ever get there, is that we started a compulsory course for medical students, undergraduate medical students in their 5th year, where they're actually doing some general practice when they work in primary care, and they recognize immediately the issues. And they keep saying, why has this not been part of medical education up until now? Why do we not know about this stuff? And why do we not have the kind of practical resources to know how to, not to advise the patients, but know how to refer them on, how to signpost them? So I think you're kind of, once people understand what you're offering, you're pushing at an open door. It's not even, don't even need to push. You can walk through the door once you get an understanding of what the shared services can do.
Thank you. So we have a question from Lindsay Montgomery, which is about whether you think there are greater application of these approaches to criminal justice than we currently see.
Can I?
Yeah, go Hazel.
I was just going to say that I recently was asked to give a presentation on the application of health justice partnerships in secure environments. And first of all, and I was talking to a bunch of general practitioners who work in prisons, and this was a kind of revelation to them. They say, oh my goodness, we didn't have any idea about this. But if you look at the social determinants of health, they are also almost identical to the determinants of reoffending. So if what you want to do is to avoid reoffending, then actually providing these services within secure environments before you send people out, you know, first of all, to reduce the stress on them, to reduce drug taking, and to help them into employment, to get them skills, all of those kinds of things. And they were saying, this is obvious, this is completely obvious, why don't we do this? So yes, I think there is a real application, particularly in secure environments and in other places as well. I can see Lindsay's got a hand up.
Yeah, I think absolutely. You know,
So I think we have time for one last.
Oh, yeah, no, go, Rebecca.
No, please go ahead, please.
No, it was sort of to back in Hazel's point, but I think, yes, it's not, health justice partnership is not just about benefit for health services. You know, lawyers also can get benefit for their clients in that recognising, you know, the impact of mental health treatment, for example, on your options in court, those kind of things. So, and we know there are lots of strategies which are about bringing health into criminal law, you know, specialist courts, etc. All of the, you know, mental health nurses in criminal courts. So it absolutely works both ways.
Thank you. So this is a great start to what is becoming in the chat a very lively conversation. I think we're going to get more and more active as the evening and the morning and the afternoon go on, depending on where you are. We're going to move on to our next presenters, but we'll continue this group conversation. That's Megan Longley and David McKillop. Megan is currently the Executive Director of Nova Scotia Legal Aid, but she also has a distinguished career working in criminal defense and other areas with youth. And David McKillop is the Vice President for Strategy and Public Affairs of Legal Aid Ontario. We look forward to hearing what you have to say. Thank you.
Hello, everyone. I'm David McKillop from Legal Aid Ontario. It's good to see so many virtual faces out there from when we were last together in Ottawa in 2019. I'm joined today by my colleague, Megan Longley, CEO of the Nova Scotia Legal Aid Commission. Our topic today is the evolution of a client-centered approach to services. Megan and I have elected not to project our PowerPoint presentation as we speak to you today. The deck is 36 pages long, and we would have to advance through it very quickly to cover everything in the 15 minutes we have been allotted. We feel it would be more of a distraction than an aid to your understanding of what we wish to talk about today. We do hope that you will take the time to go through the deck at your leisure. I think it would be fair to say that we all want to believe that legal aid service agencies around the globe put the client at the center of our programs and services. This presentation is about how two Canadian jurisdictions, Ontario and Nova Scotia, tried to take that extra step of not only putting the client at the center, but additionally looking at factors that determine who a client is and how they came to be where they are today. Only then can we truly say that we have put the client at the center. The often repeated history of Canada is that it was built on a foundation of relationship building and treaties with Indigenous peoples. That Canada was a safe haven for Black people fleeing enslavement in the United States, that it is a cultural mosaic where all immigrants are welcomed and accepted. Unfortunately, the reality is somewhat different. Canada's history is characterized by British and French attempts to control Indigenous land and resources, often through violence. The reality is that there was formalized ownership of Black people in Canada until it was outlawed by the British government in 1834. It is not just a stain on the history of the United States. The deck contains many examples of how oppression of Indigenous and non-white people continues in many respects to the present day. The impacts of this historical oppression are seen very starkly in today's federal prison numbers. Blacks make up 3% of Canada's population, yet account for 10% of the federal prison population. The numbers for Indigenous people are even worse. 5% of the population, over 30% of the federal prison population. Many of our judicial institutions and systems in particular create or maintain historical racial inequalities. This often results from hidden institutional biases in policies, practices, and procedures that privilege some groups while disadvantaging others. To start to deal with these hidden biases, LAO started to collect very detailed demographic data about our clients. A preliminary review of this data was provided at ILAG 2019 in Ottawa. Collecting race-based data allows LAO to track and barriers in service delivery may exist and determine how best to address systemic racism. Now that by seeking to understand if there is any correlation between race and outcomes. Starting July 1st, LAO will begin to collect the results of applications for bail. On January the 1st, we will start to collect outcome data for all criminal cases. When lawyers seek to have their accounts paid through our online billing system, they will be required to record case outcomes, which we can then match to our race-based data. What are we hoping to do with this information? Well, we want to identify and better understand racial inequalities. We want to be able to make evidence-based decisions to inform the development of programs and services aimed at removing systemic discrimination in the justice system and advance racial equity. And we want to be able to train and educate staff and lawyers about anti-racism and how to combat it in the justice system. I do not believe that the justice system sets out to treat people differently based on their race or ethnicity. However, I am pretty sure that when we gather together 2 years from now, I will be able to state categorically that Blacks are less likely to receive bail, or if they do receive it, on much more stringent conditions than their white counterparts. I am also quite certain that I'll be able to tell you that Indigenous Canadians will be sentenced to periods of incarceration when their non-Indigenous counterparts receive shorter sentences or are given the opportunity to access programs that do not result in any form of incarceration. It is our hope that this data will not only assist LAO to better plan our services, but to inform all actors in the justice system and begin to make the changes that will right these long-standing wrongs. In that regard, it is our hope that this data can be used to inform training for lawyers in the judiciary, inform policy development within government, recognize and support the voices of Indigenous, Black, and racialized communities when they speak about the discrimination they face within the justice system, and promote public dialogue and engagement about anti-racism. There is an idiom that goes something like, before you judge a man, walk a mile in his shoes. In essence, that is what I am hoping to do and begin the process of changing the justice system so it does not judge anyone based on the color of their skin. For centuries, Lady Justice has been depicted wearing a blindfold. That blindfold represents impartiality, the ideal that justice should be applied without regard to wealth, power, or status. I don't just wish Lady Justice to be blind, I wish her to be colorblind. Thanks very much for your attention today. I'm now going to turn the floor over to Megan for the balance of our presentation today. Thanks very much, Megan, over to you.
Thanks, David. And thank you everyone for tuning in to our presentation today. I am joining you from Nova Scotia, which is a small province on the east coast of Canada and the traditional territory of the Mi'kmaq people. David has done a great job of setting out the national landscape and some of the work that our plans are doing to start looking at people's problems more holistically, particularly with a view to ending overrepresentation of African, Canadian, and Indigenous people. Before we can get to David's vision of justice being colorblind, we need to do just the opposite. And really that's what our strategies and initiatives are designed to do, to have courts consider people and their cultural context as they are dealing with them, which is going to be essential until we have a truly equitable justice system. A little bit about the specific history of Nova Scotia in the Canadian context set out by David. Nova Scotia really does have a unique history in that people of African descent have lived and continue to live in 52 historic Black communities around the province and have done so for centuries. Nova Scotia's Black communities are not largely an immigrant population, and in fact, 77% of African Nova Scotians have been here for 3 or more generations. This is important for you to know because it requires a different lens as we look to serve our African Nova Scotian clients and communities. This information has informed the initiatives that we are undertaking. And like Legal Aid Ontario, we are trying to do a better job of capturing data about who our clients are, and in particular, people who self-identify as Indigenous or African Nova Scotian. In the slide deck, I have referred to 6 different examples of initiatives that Legal Aid in Nova Scotia has undertaken in the last couple of years, and I'm just now going to highlight 3 of them quickly in the time that we have. In the context of our legal aid plan is that we are a staff lawyer model, which means about 70 to 80% of our services are done by lawyers who actually work for the organization rather than contracting out to private lawyers. The first initiative I'd like to talk about is our African Nova Scotian social worker, who in the last 2 years has joined our staff along with our Indigenous social worker. This position has been designed to support clients in criminal and child protection proceedings. The social worker herself is of African Nova Scotian descent, which is important because that allows her to build trust with our clients and with the communities. The social worker connects clients with culturally relevant services and supports. She alerts our lawyers to barriers which may otherwise remain either unseen or unaddressed. She also educates courts and counsel on services and supports which may otherwise be unrecognized or undervalued. The social worker also helps Nova Scotia Legal Aid build bridges with communities and promote our services. I want to also draw attention to impact of race and culture assessments, which we call IRCAs, which are a tool that was created through impact litigation. At Legal Aid Nova Scotia, we like to look for opportunities to engage in litigation that may require more resources and money than a run-of-the-mill case, but will help not just individual clients, but communities and improve the system. In this example of IRCAs, our lawyers have convinced courts to start accepting reports done by African Nova Scotian social workers or psychologists, which set out a client's history, context, barriers, systemic racism in the justice system, and really allows for a more individualized sentencing process to happen, which hopefully leads to a more equitable outcome and just result. As David has discussed, people of African descent are significantly overrepresented in our criminal justice system. So considering both the context of how they came to be there and what the best solutions are moving forward will help address that impact of colonialism and racism in our justice system. As a result of the litigation that started in Nova Scotia, these IRCAs are now going to be funded on a national basis by the federal government, and in fact in Nova Scotia are being funded by the courts rather than the legal aid plans, so have made a significant impact in the outcomes for many of our clients. The final intervention that I'd like to highlight is our early intervention in child protection matters. We've created a practice group of 2 lawyers and 2 support staff who address child protection matters differently from our typical service. The service of this practice group is engaged as soon as a social worker comes to somebody's door so that people can have the advice, support, and navigation they need, including to culturally relevant supports and services. The goal is to keep people out of the court system and to help families stay together without complex and lengthy litigation. Approaching child protection matters in this way has far better outcomes for the families, but also better outcomes for both the systems in that it saves resources when you don't need to have court hearings, but also for our organization. We were finding ourselves overwhelmed by increasing numbers and increasing complexity in child protection matters, and taking this approach to either keep something out of court, or if it does hit court, to try to get it on a different path where there can be collaborative problem solving that puts the family at the center, takes the pressure off our system as well, and lets our lawyers dedicate their time on the matters where they're most needed. And again, this service intersects with our social workers I spoke about earlier, so that if somebody self-identifies, they can be referred to ensure culturally relevant services provided. I would like to thank everybody for their attention and remind you that you can take a look at our slides to get more information and links to more resources. And please reach out through email to either me or David if you have any questions or any information you'd like to share. I'd like to thank everyone for their attention.
Thank you both very much. And you've raised some really important issues that are not only issues in Canada, but in many of the countries that participate in ILAG. So thank you for that. Our next speaker will be Stephen Gibbons, who's both a lawyer and a criminologist. He works at the intersection of social work and law. And he's also the co-founder of an organization that provides legal information online to social professionals. Stephen, we look forward to hearing what you have to tell us.
Thank you for the opportunity to present our research results of a project we called the Integrated Rights Practice in the Antwerp Court Building. The idea was to tackle the non-take-up of rights of the most vulnerable people who are in contact with the judiciary. Well, I will sketch you in the first place the general context, then the research results, and we will end up with some conclusions. First, the general context. You see in front of you a picture of the courthouse of Antwerp. And you see the yellow line, that's the stairs. To enter the most important room, it's a huge room we call the Salle des Pas Perdus, it's French. In our project, there were the court registry involved, the lawyers, private lawyers, the judiciary, and social workers. The idea was bring them together so in order that they can help people in a more holistic way. The idea was to bring them together, and you see the Salle des Pas Perdus. Now it's still empty. Now they are building a huge office for the court registry, for private lawyers, and for social workers. The idea is, nowadays, if you want to find a court registry, you have entered to the building, you have to go to several places within the courthouse. For every court, there is a different registry office, which is of course not very easy to find for the citizens. The idea is to bring them all together. There will be one court registry for all the courts, and you can consult your file over there electronically. And even if you have some questions or you know nothing about your rights, or there are some social difficulties, the judiciary and nor the court registry are allowed to give you some advice to the citizens, so they can refer these people immediately to a social worker or a private lawyer who are at the same time staying in the same office. But even the idea is, you can see here a court session during COVID time, even if the judge is confronted with someone, a vulnerable people, who has no network or no help, he can refer this person immediately to the social worker. And even maybe sometimes the social worker is sitting in the court room to detect and to find people who are vulnerable in a more proactive way. We've seen here, and we talked about lawyers, about registry courts, about social workers, about judiciary. These are different legal frameworks, and there are different logics and rationalities. In the first place, we have the integrated rights practice. This is a concept of the Flemish government. It aims to guarantee social rights by creating local inter-organizational networks between social work organizations, private and public, and the mutualities that foster generalists, proactive, outreaching, strength-based, and participative social work interventions. At the same time, we have a new Act on First-Line Legal Aid and Advice and Information organized by the private lawyers. Well, this new Act aims at integrating social and legal issues by connecting their legal information tasks to the extended service to the IPR. So they are trying to install a multidisciplinary approach to social and legal problems, because every legal problem has a social context. And thirdly, there's also the new unified registry office for all the courts in the courthouse. And that's a plan of the former Minister of Justice. He called it the Court of the Future plan. What was our research question? Well, does this new cooperation between legal, social services and the judiciary lower the thresholds to assistance and services? And are the rights of clients adequately explored and realized? Well, of importance was the questioning the effectiveness of the project. And our research design was as follows. Well, we departed from a broad vision on effectiveness and evaluation, a critical realism as the underlying science philosophy paradigm, and we used the KIMA model as a conceptual framework. KIMA stands for the clients, the aims, the interventions, the mechanisms, and the results. Our research methods, the KIMA model, but also the observations and interviews. And the first phase was the interview of the representatives of the project team. And second phase, we used a more mixed method, but with observations, interviews, and the analyzing of the registration data. What were or are the research results? In the first phase, about the objectives of the partners in the project, they were trying to achieve a transversal cooperation between social and legal actors. But especially, and that was very important for the president of the Court of First Instance, was to provide a warm welcome. A lot of people, or many people, are entering the courthouse every day, and they are not knowing where they have to be. They have a lot of questions and don't feel at ease. By providing a one-stop shop and one big office for all the questions people have, they hope that they can provide a warmer welcome. They also wanted to try to reach the vulnerable groups that are otherwise hardly or not at all being reached. And of course, they want to optimize mutual cooperation. But there were some impeding factors. Of course, there are differences in organizational culture between the three core actors, and they were trying to reach what we called a unity of effort. The impediments were difference in culture among social organizations, between private and public social organizations, which have different scopes and different aims, but also between social organizations and the judicial partners. Of course, there were power differences. There's a dominance of the legal profession and, of course, a judicial power. And we saw that social workers were admiring the judicial authority and the legal professions. We also have seen some differences in information sharing. What about secrets? What kind of information can be shared? And we saw a lot of a lack of data about vulnerable people within the court building. There were no information on internal flow and external flow of the clients. In phase 2, we observed the consultations, and we did some interviews of clients a few months after their consultation, but we were interested to know what happened afterwards. We have seen that there was no cooperation between social and legal actors. The social worker only had a limited input in the conversations, was hardly recognized by the client as such. Although a social worker stands for relationships, proximity is client-driven, and everything depended on the interpretation that the lawyer gave to the conversation. But the lawyer stands for more rationality. It's a more on a distance and is fact searching. About a warm welcome, we are very hopeful. People find their way to the information desk and are referred to the legal and social info points and social workers and the private lawyers. And social workers were recognized as friendly, but they did not present himself as social worker, and the client didn't know who was this guy who was helping him with information or coming from the waiting room to the consultation room. He was very nice and very friendly, but who was he? And the lawyer was well recognized as such, but did not present himself as such, nor he present the other guy, the other person during the consultation as the social worker. And vulnerable people were hardly reached. The working principles in phase 2, well, social workers often reduce people's problem to legal issues and refer the clients to the private lawyers instead of detecting and questioning the social needs of the clients, and if there was a legal issue, then refer the client to the private lawyer. We saw also a more authoritarian approach by the private lawyers, rather than a client-centered approach by social workers, but the social worker wasn't visible and couldn't intervene into the process. So social workers have practiced wisdom, are working alliance, they have their own logic, but it was not visible at all. And the private lawyers, they were on a distant, more problem-focused, atomizing problems to purely legally problems. So the broader context of a client's problem was often ignored. There was no proactive search for other related issues, multi-problems during the consultation. The lawyer was focused on the question, the legal question of the client, but didn't search for other related issues. What about outreach? The social worker have rather limited contact with the judges. And the judges were hardly aware of the social workers being in this building and didn't refer clients to their offices. Social workers hardly have been present during court sessions. And social workers were present in the waiting room for legal aid in the courthouse. And that was very helpful because there a lot of vulnerable people could be reached. But there was no follow-up of the clients after the consultation. So often clients didn't know where to go or didn't go further to find a solution for their problems. Conclusions. Well, collaboration between social workers, lawyers, and the court administration, judges, is not very easy to implement successfully and needs more interdisciplinary partnerships, sharing of knowledge, internships, intervisions, more insights into the process, logic, and rationality of the professions involved in this project. The concept of the integrated rights practice could not be fully applied, although for the continuation of the project, the goals and principles still remain directive. This kind of concept. Some adjustments on the concept of IPRI need to be done, such as a physical venue that is staffed by social workers and lawyers on a more permanent basis instead of a kind of concept and that will bring people together. And of course, very important is a broker, someone who really can make the connection between the two different worlds, the social profession, the legal profession, and who can overrule the experience, power, and hierarchical relationship between the different professionals. And at least, a more organic way of building a social legal venue leads to a more successful access to justice instead of implementing a concept top-down. What was the idea of the Flemish government? And even now, the Flemish government sees that it's very important to start more organic and to see how they can make some further steps. The project is still going on, and they are now in the phases of sharing of knowledge, internships, more insights, and they're evolving to a more or less stable interdisciplinary partnership. I thank you for your attention.
Thank you very much. So we have a question that's really broad, but it follows directly on a point that Stephen made about getting, I could put it this way, getting lawyers to see the broader context of their clients' problems. And so someone, actually more than one person, has raised the issue of whether that's a different kind of challenge in the criminal context than in the civil context. And I would welcome the panel's thoughts on that. Like, is it harder to get criminal lawyers to see that their clients are embedded in complex life issues just like everyone else than it is to get civil lawyers who are involved in health justice partnerships, working around housing or something like that, to notice those issues?
I'll jump in on that. I would a little of each, I think. I think the criminal lawyers really see the context because they need to see it to particularly if a matter reaches a sentencing stage in a criminal proceeding. What I find in my jurisdiction is the challenge is to get them to do something about it, because the many of those services I was talking about earlier are would require an extra step. They're not right there in the criminal process. So I think while people would recognize it, it's normalizing the warm welcome concept, the warm handoff to the services, or engaging social worker or other staff who can help, and court support workers.
Do other folks have thoughts on that? I mean, there's something about the voluntary nature of entering into the relationship with the lawyer that may be playing a role here.
Becky, it partly depends on how you pay your defense lawyers. The defense lawyers in Scotland hear what we say about holism, and the public defenders, they say public defenders have got more time to do this in Scotland, whereas we private lawyers, we're only paid to deal with individual legal problems with clients. We're not paid to work with social workers. I'm not saying it's true, but that is their reaction.
In my model, the vast majority of the criminal work is done by legal aid staff lawyers, so that tension doesn't exist as much. But it's they're located in separate offices in the cities. In rural areas, all of our practitioners would be together, but it's having them remember that across the hall are folks who can help with the greater scope of issues. But as we do things like the impact of race and culture assessments, it really does start doing a much better job of thinking holistically in a criminal context, not just in a family, child protection, or civil context.
And in contexts where jurisdictions are becoming more conscious of racial diversity and of systemic racism, are there insights that you have from your own work that can help other jurisdictions that are trying to grapple with those issues, help that be a part of these partnerships?
In our case, I think the lawyering piece had to come first, because it took some work to convince courts that things like systemic racism and cultural context were important and relevant and needed to be considered and addressed. And prosecutors, at the outset were arguing that this was not relevant information, didn't want the writers of the report to be declared experts. And once the lawyering piece, worked through those strategic litigation pieces, then everybody started to think differently. And now Crown attorneys welcome these reports, judges welcome them, and what that means is everybody is starting to think more broadly about clients, more individually about clients. So the lawyering piece had to come before the holistic piece, but it feels, you know, very much like that shift is happening
Thank you.
when it comes to.
Thank you. I think we have a question or a comment from Colin.
Thanks, Becky. It was really just to follow up on the discussion about criminal practice, and my question in the chat really gets at the point that Alan's raising, is how can you pay for or how can you encourage or embed different forms of practice when the atomization that Stephen talks about is almost inherent in a case-by-case piece rate payment model. So that's a kind of general question. There is an example from Scotland, which is actually built on practice in the US about trauma-informed approaches to criminal practice, recognizing the impact of adverse childhood experiences and bringing that to bear on negotiations with prosecutors about the path of a case, or in sentencing discussions with the court to try and encourage the court to take a more trauma-aware approach to sentencing. The interesting thing about that, the advent of that in Scotland, is that it's almost happened outside the legal aid system. It's particular lawyers who have, if you like, made it their personal mission to embed those approaches. And while on the one hand, I know that there have been some tensions in those particular businesses because it takes time and effort, and it's time and effort that is not necessarily remunerated on a case-by-case basis. What I think we're seeing is that the prominent business in that area is actually attracting more clients because they're becoming known for that approach. They're becoming known locally as the kind lawyers. And so it is driving business to them, albeit they're not being paid for the extra work that they're doing to embed that into their practice. So it's really, I'm really interested in whether there are judicare models which have found a way of building in payment for that kind of work so that it can become part of general practice rather than relying on individual lawyers making it a personal mission.
So this is such a great conversation that I, as moderator, have to enter into it and pause it so that we can move on to our next presenter. But it's a wonderful example of how robust this discussion has become. Our next presentation will be from Hazel Genn, who I think is probably known to everyone here. She's currently professor of sociolegal studies at UCL. She's done many things, but the easiest way to summarize them is to say that she's a leading empirical researcher and expert on access to civil and administrative justice. And Hazel, we look forward to hearing what you have to say.
Thanks, Becky. I'm adopting the high risk strategy of doing this live and attempting to share my screen. So I'm going to try and do it now because I've got some slides. Will somebody waggle their hand at me if they can't see this? Or no, can you waggle your hand if you can see this? So just to say that Susie set out the basis of health justice partnerships very well. And what I wanted to say is that we've had some form or other of health justice partnerships in England and Wales, at least since the early 1990s. And what I want to do is to say something very briefly about the current state, just to say a few words about the pilot health justice partnership that I set up in East London a few years ago. And then to talk a bit about the impact of COVID and where I think potential change is happening in relation to policy on integrated health and social welfare legal services, because I do see some changes. I've been working in this area for the last, I don't know, 5, 6, 7 years. And I do in the last couple of years see the beginnings of change and the beginnings of growing interest on the health side in thinking about how better to integrate health and legal services. So the first thing to say is that we did a mapping study of the health justice landscape in England and Wales in 2018, and we found over 350 collaborations between health and free social welfare legal services across England and Wales. We didn't include Scotland, and I know that there are lots in Scotland. Very many different models of collaboration. So there isn't one model of a health justice partnership, very many differences. There's a spectrum from fully integrated services to very loose referral services. So in the fully integrated services, you've got lawyers as part of the healthcare team, you've got co-location, And then going down the spectrum, and sort of as it becomes a looser relationship, you have pop-up services, co-located link workers that I'll talk about later on, and then quite loose referral services. The important thing to say in terms of policy and strategy is that these are grassroots local initiatives. So health justice partnerships have grown up as a grassroots movement in England and Wales. It is not something that has been organised at a strategic level. The funding of these partnerships is extremely fragile and very highly dependent on local initiatives. So on a local authority that gets it, on a local clinical commissioning group that gets it, on a charity that gets it. There are many, many different ways, but the majority of these collaborations, although some of them have been quite long-standing, the majority of them are looking at only 1 to 2 years funding. So they're constantly scrabbling for money. And that's why my kind of current mission in life is to try and persuade people. What I'm advocating for is a strategy on support and development of these partnerships that will make them more sustainable. I can speak from, when I intervened earlier on, I was speaking from personal experience, because when I was Dean of the Faculty at UCL Laws, we set up a Centre for Access to Justice, and one of my visions, I may have spoken about this at an earlier ILAG conference, I can't remember now, but anyway, one of my visions was that we would have a co-located service with a general practice. So a service of a legal clinic of students, law students, supervised by qualified lawyers, that would provide a service to the local community. And we set this up in East London, in one of the most deprived areas, one of the most deprived local authorities in England and Wales, and possibly in Europe. And what we set up was a co-located legal advice service that provided full representation. So not just first line advice, but full representation and casework for GP patients. The GP practice that we went into partnership with absolutely got the idea. They were keen on it. We were in the same building, and the GPs would refer patients to us, or patients coming into the building to see the GPs would see our leaflets or our signs and could think, oh, maybe I could go and see those people. And they would see them, and we would see them either immediately if we could, or we would make an appointment for them to come back. So it was a direct referral service or self-referral service within the same building as the GP practice. It provided great education for the students. We also did some outreach with the community, and we did a bit of research trying to evaluate the impact of the service. I'm not going to go into that in too much detail. I just want to say that the matters that were either referred to us or brought to us by patients of the practice, largely around things like housing, welfare benefits, a little bit on family and employment, a little bit on immigration, but the vast majority to do with housing and benefit standard social welfare advice services. And someone asked earlier, what do the practitioners think about it? Now, this is one of the, during the research, we talked to all the GPs in the practice, and one of the things, the quotes that I think really tells you a lot about what we are offering to the practitioners, is that they recognize that they see people are coming with symptoms, but they know that underlying the symptoms are what they call social problems. They don't call them unmet legal needs, they call them social problems. That's why they don't understand the word legal. We don't have a common vocabulary between social welfare legal services and health practitioners, and that's something we need to develop. But what they say is that it's a lot easier to medicalize problems than to address social determinants of health. You've got 10 minutes, people have multiple problems. It's easier to ignore the problems, to take it on, and particularly if you don't know what to do with it. And they also said that the co-location element was important. Patients delighted when you say, we've got this service and you can go into the next room. I could give you loads of examples of ways in which we help people very, very quickly that were referred by the GPs, but I haven't got time. So what we need, bearing in mind that there are over 350, 380 collaborations, grassroots collaborations between health services, both in primary care, but also in hospitals and other health settings. But we have this, that it's kind of spotty, it's serendipitous, and there's no sustained funding. What we need is a coordinated policy that focuses on benefit to the system, not siloed departmental thinking, but how do we deliver services to people in need, and often people with very complex needs, in a way that actually benefits the citizen. And integrating legal services and health is not the complete answer, but it's one of the things that you can do. And I agree with Susie that we need to develop a robust evidence base, but too much emphasis on the need for a robust evidence base gives policy people the excuse for not doing anything. They say, well, it's a great idea, but actually we need much more evidence on this. And sadly, although I think the Ministry of Justice is very interested in this, I keep on seeing things about the need for more and more evidence. So what I want to say is that I think that COVID has given a bit of a kick up the backside to developments in this area. Because of course, one of the things in the UK, we've been particularly badly hit by COVID. And one of the things that COVID has done is to shine a real spotlight on health inequalities in the UK. And there's much more talk about health inequalities, much more talk about the wider determinants of health, and also the impact of COVID, but also of lockdown on a range of issues that have affected people on low incomes and in disadvantage, in vulnerable groups. And that focus on those areas, I think, has created more of a space or more of an opportunity to talk about integrated health and legal services, because people are talking much more about, you know, not just describing health inequalities, but saying, what can we do about health inequalities? What can we do to address the wider determinants of health? And of course, when you say, and I think Susie used this term earlier on, when you say, well, actually, free social welfare legal services can be seen as a health intervention, people within the kind of health policy sphere stare at you aghast. But of course, it is a health intervention. If it can be seen as a health intervention, if by improving somebody's material well-being or removing the anxiety that is stopping them from sleeping or making them depressed about being thrown out of their house or wrongly thrown out of their job, or not having enough money to feed their children because they're not getting the benefits they deserve, if you can, through free social welfare legal services, provide them with that improvement in their material well-being, you are going to have a knock-on effect on their mental and physical health. And as Susie said earlier, you know, that's part of the kind of theory of change that underlies the idea of integrating services. So what has the impact of COVID been? Death in the UK, death rates in the most deprived areas much higher than all rates of death. So it was clear, we knew about health inequalities, but what COVID did was to demonstrate the extent to which people who are already suffering from challenges and deprived areas and health inequalities were more likely to die from COVID. The other thing that was highlighted a lot in the news was the effect of lockdown, the effect of people being put on furlough and various other things, increased need for welfare benefits, increased problems with debt, housing anxieties, concerns around employment, lack of access to community care, increase in domestic abuse, increase in problems around child protection. So a range of issues that legal practitioners very used to dealing with actually being highlighted in the news and media as direct effects of COVID and the impact of lockdown on citizens. Also, COVID.
2 minutes, Hazel.
Oh, good grief. All right. Well, so the other loss of provision of advice. So what I'm going to move on to is why I think that there is change ahead, why there might be change ahead. Prior to COVID, the Ministry of Justice was within their proposed changes to legal support, they actually spoke about co-located health and legal services. That was all ditched when we went into lockdown, and they're now starting to think about it again. We have developments in terms of social prescribing, where healthcare practitioners recognise the need for non-medical services and are encouraged to spot the need for other than medical services, and they're being encouraged to spot indicators of need for social welfare legal support. General practices are encouraged to have, well, they're provided with what are known as link workers, who link patients from the practice with non-medical services, and social welfare legal services are seen as one of the services that they can be linked with. The other thing that is actually really helpful is a recent white paper. There's another reorganisation of the National Health Service, and in the white paper they talk a lot about integrated care, and one of the things that I've highlighted at the bottom of this slide is the idea that integrated health and care partnerships are now statutorily required to work with the voluntary and community sector, which gives a sort of a guidance from the top to say, actually, you should be doing this. And the other thing I would say is that there's a growing interest in education for healthcare professionals, and at UCL we're actually providing a compulsory course. So all medical students are forced to listen to me and a colleague for 3 hours during their course on health justice partnerships and its role in health inequalities and the role of law. And before you cut me off, Alan, I'm going to do a plug for a launch of a stream of work that I'm doing, which is called Law for Health, with UCL School of Health for the Public, because actually law is now beginning to be seen, law and free legal service is beginning to be seen as a central part of what should be a central part of public health policy. And there you are, stopped. Questions?
Well done, Hazel. We'll send out that plug to those who are attending. Back to you, Becky.
Anyone who wants them can have the slides. I'm very happy for anybody to have the slides, and you've got that plug on there.
Okay,
okay, thanks. I'll stop sharing.
Thank you, Hazel. So we have one question for the entire panel, and it goes like this. The models that you're describing start with clients, and then they move to individual providers, and they start at the ground and then they move up. And that's a wonderful model of what you're thinking about, is helping people in their own lives. But do you have insights about how we can scale that?
Can I say that in scaling that, I think there are two ways in which you can do it. So first of all, and the way that I'm approaching it is to say that if you can kind of get people at a strategic level interested, and you can get kind of direction, because I think these are services that have to be designed and delivered locally based on local need and local provision, but that you need that kind of strategic leadership that gets people thinking about this and gets the local decision makers who've actually got their hands on the money to do something. The other thing I would say, which is what I say to public health people, they say, yeah, but this is all about kind of individual situations. You know, you're just helping an individual person. But actually, one of the things that you find, and that people will know, is that if you have a collection of cases that are being challenged by social welfare lawyers, where you're challenging the approach the local authority is taking in the way that it's dealing with housing matters, or if you're challenging the way that decisions are being made about benefits and things like that, ultimately you can have an effect. You're going to have an effect that may change decision making at the kind of meso level, the institutional level, that actually will have a broader societal public health impact. So yes, you're starting with helping the individual, but the more you do of this, the more activity you have, the more challenges you have, the more that you say, actually, this needs to be implemented differently or properly, the more I believe that you can have that kind of institutional impact, that wider institutional and public health impact. There's at least the potential for it.
Can I just add in there that in scaling a model doesn't mean that the model has to look the same everywhere. And that sort of, again, just reflects Hazel's point that if you're talking about place-based initiatives, you've got to respond to what the local context is and the capacity to partner. And partnering can happen in a whole range of different ways and should. But then there is that point about the enabling environment, and just a very simple thing, even the way services are funded, and therefore services think about the value of what they do. If you're thinking only about your impact in terms of a legal outcome or only in terms of a health outcome, you kind of miss the opportunity to think about wellbeing more broadly. And I think, you're not, as we've heard in the discussion here, you're not funded to help them with things beyond their justice problem, even though it might be that the health assistance someone gets does more to address their legal problem, or vice versa. So I think, how do we deal with the fact that strategies outside our area of expertise may have an equal or greater impact on the outcomes that we're seeking? So I think that's just an interesting one. Challenge for us all.
Absolutely. Thank you to all of our presenters and to this wonderful group of people who had such an interesting conversation and questions to offer. And now we'll bounce it to Alan.
Thanks very much, Becky, and to the panel. What a wonderful session. Fantastic. Can I remind you all that those of you who are going to stream 6B, Wayne is going to put the link up for those of you who are going to channel 6B. Those of us who are going to 6A will stay on this stream. We've eaten 5 minutes into the break, so I intend that we'll start at 10 minutes to the hour. We will resume both streams at 10 minutes to and take a break now. Thanks to everybody.